Very good morning, guys. Can you see me? Can you hear me? Hope I'm audible and visible. Just give me a second. Sorry. So welcome. So today, what we'll be discussing about few syndromes. Few syndromes I thought would make sense to discuss, and from a pathological point of view. Fine. So here we are going to discuss about like neurofibromatosis 1, 2. Your tuberous sclerosis. Generally, we read them in bits and pieces. We'll just go through the criterias. We'll try to give reason why this is important, why this criteria becomes important here, and few microscopic appearance of the cases, what you're going to see, the differences between them, and then we'll see how to diagnose them as well. Right? So we go to the first one. As to start with, if you're a Plus subscriber, you'll get all these benefits. You can access both live and recorded, and hopefully we'll be rolling out the printed options of notes soon. We have started, the proofreading is done for pathology. Hopefully it will come out soon. Right? And you can attend any of the special classes which will be free for you guys, and hope to see you guys in this list next year, coming year. Fine. So let's start. So these are the syndromes we'll be discussing. We'll be having two sessions, one today at 10, right, and one tomorrow at 10. Hopefully we'll be able to cover all of these. These are from WHO. Most of these syndromes in WHO are discussed from the neural perspective, because all these syndromes here, whatever you see, most of them has a CNS involvement, in addition to obviously other involvement as well, right? So CNS includes your brain as well as the peripheral nervous system, right? So we are going to see that. Hopefully we'll be seeing 1, 2, 3 and 4 today, and rest of them tomorrow. Okay, so let's start. The first one we're going to see about is neurofibromatosis. I'll have a quick look at the pathogenesis first, then we'll go to the criteria, and then we'll go how to diagnose them on a microscopy, right? What do you think is the gene mutated in neurofibromatosis? I'm sure you must have known the chromosome and gene. Neurofibromatosis, the gene mutated in neurofibromatosis. Okay, you have your NF1 gene, the NF1 transcript, which codes for a thing called as neurofibromin. Okay, this neurofibromin is a person, the NF1 neurofibromin is a person which is going to be mutated. Neurofibromatosis, NF1, the neurofibromin is actually a tumor suppressor gene, right? So this tumor suppressor gene, tell me what type of mutation you'll have, gain of function mutation or a loss of function mutation? You'll have a loss of function mutation, right? So the disease causing mutation is going to be loss of function. I'm writing yellow in the corner. We'll see the normal function of neurofibromin, then we'll see how it's going to cause the disease, right? When I say neurofibromin, actually it is nothing but a part of a gap domain, right? Neurofibromin, this protein, is a part, it's not exactly the gap domain, part of gap domain. You must have heard about gap when we read about RAS pathway. So the gap stands for your GTPase activating protein. Fine. We are not talking about the mutation, we are just talking about the function of neurofibromin here, right? So GTPase activating protein. So what happens when in normal function of gap is, let's assume I'm having a receptor, some XYZ receptor. The downstream pathway of this receptor is RAS. Generally, RAS will be in an inactive state, right? Only when there is a growth factor which binds to the receptor, RAS will become active. I'm just writing RAS for inactive RAS. It becomes active RAS. This RAS, active RAS, will give to the downstream pathway. If it's a cell proliferation, it helps in cell proliferation. That's what it normally does, right? Let's assume that this RAS will be active till the receptor is there. Let's assume that growth factor is gone. Well, a cell will not always be in the growth phase, right? So the growth factor goes away. This RAS active should automatically come to an inactive RAS, right? It should become, right? So this inactive to active RAS transformation is because of the GTP. When GDP becomes GTP, the activated phosphorylated form, it becomes active. So what makes it inactive is my GTPase activating protein, right? So this is neurofibromin. So what neurofibromin does is make sure an active RAS in the absence of a growth factor will automatically become an inactive RAS, right? This is the normal function. In other words, gap will suppress growth, right? It has to suppress growth because it's converting an active to an inactive RAS. So when I have a loss of function mutation, this gap is not available. Let's say a growth factor came, it caused a stimulus and it became active RAS, it causing cell proliferation. In patients with neurofibromatosis, do you think they'll come back to normal? they won't come back to normal, right? So which means even in the absence of growth factor, they'll be constantly being active. That's a problem in neurofibromatosis. So it's a problem in RAS. It's not just based on RAS. RAS has multiple effects. That's why in neurofibromatosis, I have multiple downstream effects. Like I have neurofibromas, you have plexiform neurofibromas, you have Kaposi spots, lots of them are there. Because RAS is one of the signal transduction protein. It has below that, it has RAF pathway. You must have read about BRAF mutation, right? That pathway is also linked to RAS. You have your phosphoinositol triphosphate kinase pathway. You have your mTOR pathway. mTOR is the one which is more important in the cellular proliferation, and you have an AKT pathway. So when RA is abnormal, it can downstreamly activate any of these pathways. That's why I have a multi-system involvement, because it's maybe RAF is present in a single lesion, organ. PH3K, mTOR, AKT will be present in other organs. So I have multiple effects, right? That's the reason for the systemic effects of neurofibromatosis, right? It's not just one, it has multiple downstream pathways, fine. Good morning, Priyanka. Fine, so we did read about little bit about the pathogenesis of how these things happens, right? So let's go and understand, when I have multiple effects, I am right in saying that this patient can present with this pathway defect alone, or can present with 1 and 2, or can present 1, 3, 4, any permutation combination. Yes, it's not that always a patient should have all the pathways activated, all the symptoms present, right? So it's possible that I can have different clinical manifestations, right? I can have a different clinical manifestations. This, if you remember, I'm trying to relate to our understanding to your genetics again. Good morning, Swati. What I'm trying to relate is, when I have a mutation, I can have different clinical manifestations, or some of the time I won't have any clinical manifestations. All of them are suppressed. Some only 2, only 4, right? This is what we read in your autosomal dominant disorders as variable expressivity, right? And your incomplete or complete penetrance. So this disease can have a variable expressivity and incomplete penetrance just because it's having multiple downstream pathway. So these means it has to be an autosomal dominant disorder, right? Only a dominant disorder can have a problem. I'm going to call it an autosomal dominant because the chromosome, the neurofibromin, is in an autosome. It's in your 13th, it's in your 9th chromosome, right? So it's definitely an autosomal dominant pathway only, right? Okay. So now here, we are again trying to extrapolate one more thing. When I'm having an autosomal dominant disease with multiple variations in clinical feature, can I say that, okay, I can diagnose this patient, every patient of neurofibromatosis with the presence of neurofibroma? I cannot, because they might have neurofibroma, they might not have neurofibroma. That's the reason in most of the autosomal dominant pathway, whatever diseases we are going to treat today will have criteria for diagnosis. It's not just one unique thing. We have lots of criteria to come to a diagnosis, right? So we're going to look at the criteria for diagnosis of neurofibromatosis. The criteria of NF2 has been evolved a lot. The criteria of NF1 has always been more or less the same. There are few things which you have to note very carefully in the criteria. We look at them. It's by National Institute of Health, the criteria provided by NF1 neurofibromatosis, right? NIH has laid down the criteria. The first thing is, I'm sure you must know the skin lesion which happens in neurofibromatosis. What is that? Kaposi spots, right? We look at, when we go in detail, we look at how a Kaposi spots look in a microscopy. Because Kaposi spots, if you look at Kaposi spots, it's not just Kaposi spots. We have size criteria. If you remember something without a reason, we might tend to forget it, right? We'll give it a tiny bit of reason and let's try how to identify it. They've kept a number of 6 or more criteria or more Kaposi spots. Okay. Not only that, if you look at them, I have 2 things. One in prepubertal gender and one in postpubertal person, right? In prepubertal person, if Kaposi spots are approximately more than 5 millimeter, I'll consider it an inclusion criteria. In post-pubertal person, I'm not going to consider more than 5 millimeter. It's going to be more than 15 millimeter. Why this size criteria became important is what we're going to see now. I'm having Kaposi spot. I'm right in saying that a Kaposi spot is nothing but a pigmented macule in the skin. Yes, definitely right. So it's not a problem for an Indian population where my pigmented macules in the lesions are very, very rare. When you go to a Western country, where these diagnoses are more common than Indian country, a Western population, is there a possibility of freckles? Do they have freckles? They will have freckles, right? So can a freckle mimic a cafe spots? Freckle is nothing but a depigmented macule. Definitely a hyperpigmented macule. Definitely it will mimic a cafe spots, right? So this closest differential diagnosis, freckle. Clinically, the closest differential diagnosis, freckles. The problem for me is microscopically also it will mimic the same freckle. That's the reason I'm having this criteria. Because if you remember your dermatology, if you remember reading freckles, you must have said that with the help of the puberty, the hormonal change, the freckle increases in size. Which means I need this number of 6 more than 6, right? Good morning, Jay. I need more than 6 for me to say, okay, it's not a freckle, I'm going to think of a syndromic thing. And when it's post-pubertal, freckle grows. Definitely, so I have to increase the size of cafe spots also. In microscopy, both cafe spots and freckle will have the same appearance. So even if you take a biopsy, I cannot rule out it's cafe spots or freckles. The only thing I'm going to see in both of them is the ratio of, there are 2 points which you have to understand. First thing, the ratio of melanocytes to keratinocytes will be increased. It's normally said that I will have 1 melanocyte per 10 keratinocyte in your basal layer. That's a normal ratio. The normal ratio is 1 melanocytes is to 10. 1 melanocytes and 10 keratinocytes is nothing but a squamous cell, that's all. Fine. Second, there will be increase in the clustering of melanocytes as well. It's more melanocytes. When more melanocytes happen, I'm going to have more amount of pigmentation, which makes it a hyperpigmented macule, right? So this is what I'm going to see in microscopy, both for freckle as well as cafe spots. So I'll not be able to differentiate them. That's the reason the size becomes important, especially in a post-pubertal person. You have to look at the size, right? That's more important for you. Second, neurofibromas. Neurofibromas have different types of neurofibromas. I can have we'll not go to neurofibromas, we'll go to whatever is related to pigmented abnormality itself. I can have freckles. If you read about freckles, where do you think freckles are common? Is it common in your sun-exposed area or non-sun-exposed area? Generally, freckles are very common in the sun-exposed area, right? When I'm having a freckle in an axillary region or an inguinal region, which is not exposed to sun, so here, then my differential diagnosis goes away. So I can easily put that it's a cafe spot only, right? Freckling, it's not freckles. Freckling appearance seen in your axillary region or your inguinal region. So these things will make sure that I am going to rule out freckling. That was the only differential diagnosis clinically as well as my microscopy. So I can be more confident this is a syndromic problem, right? That's the second one. Third, I'm sure you must have known this finding in your eye, which is Lisch nodule. Lisch nodule is nothing but iris hamartoma. Actually, iris hamartoma, also the color is the problem. There also the problem is pigmentation only. In the skin, I call it cafe spots. In the iris, I call it Lisch nodule. That's all, right? So Lisch nodule, again here I need criteria because I'm sure you must have looked at the iris. Definitely be pigmented. If you carefully go and look, there will be tiny places where that can have more pigmentation. So one tiny pigmented nodule, I'm not going to call it an iris nodule. I should have 2 or more. When you have 2 or more nodules in the skin, so in the iris, this is actually iris hamartoma. So when I say it's the same pigmentation problem, this iris hamartoma also will have the same appearance like my freckle or your cafe spots, clustering of melanocytes, that's all. Right? It's just an hamartoma. Hamartoma means excess presentation in the normal tissue, that's all, right? So all these 3 are related to my pigmented problem, right? That's one. So we said neurofibromatosis. So we have to look at the other one as well. I'm going to look at the neurofibromas. Again, when you go to neurofibromas, I have lots and different types of neurofibroma. One is a classical neurofibroma, a superficial one, and a diffuse one. Those are 2 possibilities. Other one is in plexiform neurofibroma. We look at both of them, how to differentiate them on a microscopy, right? The 4th criteria is based on neurofibromas. When I say neurofibromas, again, you must have seen patients with neurofibromatosis who have neurofibroma throughout the body. I don't want that. 2 or more neurofibromas is more than enough, right? When I have 2 or more of any type, it doesn't matter what type it is, but I should have 2 or more neurofibromas, because neurofibroma is again an extremely common disease. So 1 neurofibroma is not enough for me to diagnose it. Of any type. Like I said, the types are your just a second, your plexiform or superficial or diffuse neurofibroma, or When I have plexiform neurofibroma, even one is enough to think or suspect neurofibromatosis. So we have to learn what a plexiform neurofibroma is, right? Plexiform neurofibroma, even if it's one, it's more characteristic of a neurofibromatosis than a typical neurofibroma. So we have to know what are the different types of neurofibroma available. So there are definitely more than one neurofibroma available, right? So superficial neurofibroma, a diffuse neurofibroma, and a plexiform neurofibroma. Superficial and diffuse is not anything different. Superficial is like a nodule, diffuse is in multiple places, that's all, right? So I'm going to look at the neurofibromas a little bit in detail. So I said that one, I'm going to have normal typical neurofibroma, other one is a plexiform neurofibroma. See, both of them are neural related, right? When I say neurofibroma, it has to arise from the nerve. It becomes like a nodule because it grows, outgrows, and becomes like a nodule, right? One thing what happens is, let's assume that this is my nerve. Okay, you will have nerve, the endoneurium, peritoneum, everything. So it will come from the nerve and it will grow like this. Okay, normal neurofibroma will grow like this. A subcutaneous nerve is enough, or any nerve in the body is enough. It's going to grow up. So it can be seen as a polyp-like condition in the skin, or it can be seen just like a bulge. Both of them are possible, right? So it will be attached to a nerve. Okay, any neurofibroma will be attached to a nerve. If it's simple neurofibroma, it's superficial. Diffuse neurofibroma, maybe a little bit underneath. That's all. When I say plexiform neurofibroma, good morning, Sam. So when I say plexiform neurofibroma, it's not going to become attached from a nerve. It will expand the nerve, right? It expands nerve. Why? I'll tell why plexiform neurofibroma is more important and more suggestive of neurofibromatosis. Let's say that I'm having a nerve like this. I'm just going to draw a nerve in the center. Is there a possibility that the nerve might get injured at one, like if there's a tiny bit of injury in the corner? Is there a possibility I can have a neuroma? You must have heard about traumatic neuroma, definitely. So if there's a tiny bit of injury, which can be anything, I can have a tiny swelling here, right? It's possible. It can grow. In response to damage, it can grow, right? Okay. Priyanka post. No, Priyanka. Neurofibromatosis is not affected by hormones. The closest differential diagnosis of Kaplan-Meier spots is freckles. Freckles can be affected by hormones. So when it goes post-pubertal, I will have a difference of opinion clinically when a person looks, is it a neurofibromatosis or a freckle? So even if it's a freckle, if it grows in size more than 50 millimeter, it is definitely abnormal. So I'll put it into Kaplan-Meier response, that's all. Okay. Fine. So when I have a trauma or any injury, it can grow, right? So it will be attached to it. When I say expands from a nerve, which means assume this is a nerve, and the impulse for this happens from inside. There's a tiny damage here, which is unlikely. I cannot go into the nerve and injure the nerve, right? So if a damage happens here, and the nerve is going to grow, it grows like this. The entire nerve grows. So the damage is from within. If the damage is from within, it is definitely correct saying that it's a mutation related damage or not a trauma related damage, right? So even one plexiform neurofibroma, I'm 100% sure that there's some mutation affecting one of the nerve fibers deep within, and which is making the nerve bigger, right? It's damage from within. Okay. That's the reason plexiform neurofibroma is very, very characteristic of a neurofibromatosis, fine? Both of them are good enough to diagnose. Again, I need more number, 2 or more for normal, and one plexiform neurofibroma is more than enough to consider as a criteria for neurofibromatosis, right? So when I say neurofibroma, I have to look at the microscopy. I'm sure you must have looked at, you must have read about everything about the microscopy of an schwannoma. Neurofibroma almost will be equivalent to schwannoma, except one finding. What is the finding? You will not see in a neurofibroma, but you will see in a schwannoma. An MCQ based on this came in your exam. You won't see one finding in schwannoma. Sorry, you won't see one finding in neurofibroma, but that will be present in schwannoma. That's actually diagnostic as well. The finding is captured. Okay, let's see. you won't see the verrucate body, right? Verrucate bodies will not be present in neurofibroma. Verrucate bodies is a classical finding seen only in schwannoma. So what do I see in neurofibroma to identify it as neurofibroma? I'm going to base on the nerve fiber only. I hope you must have seen the nerve fiber in a microscopy. If not you must have definitely seen your Paxinian corpuscles in your histology, in your dermatology. It kind of looks like that, right? So when I say microscopic appearance, they're going to be spindle-shaped cells. They'll have kind of a wavy appearance. The wavy appearance is more characteristic. It looks like a Paxinian corpuscles, right? It'll be like wire-like. When I'm talking about neurofibroma, there will be no verrucate bodies or your Antony A, Antony B pattern. Verrucate bodies, I'm going to call it more characteristic because Antony A, Antony B pattern is a bit non-specific because it's based on cellularity. I can have a neurofibroma with more cellularity and less cellularity, obviously, right? Okay, so that's going to be helpful for me for diagnosis. When I say it is a wavy condition, I can have fibroblast as a differential diagnosis, normal fibroma, not a neurofibroma. So which means I need some marker to say it is neural origin, right? I'm sure you must have known the marker for schwannoma. I need an IHC. The same IHC will be positive here as well. S100. S100 says it's originating from neural crest, that's all. Anything from neural crest will be S100 positive, that's one marker. If you want a better marker, SOX10 is a very, very good marker. Even if S100 is negative, SOX10 will be positive, but again, SOX10 is difficult to available in the lab, so I'll go with S100, that's more than enough, right? So plexiform neurofibroma also look the same, wire-like, spindle-shaped wavy fibers, same thing, but the look is different, that's all, fine? When you look at this, you can definitely see that it's from a skin nodule. You can see the waviness here, right? The waviness is diagnostic of a neural origin. Definitely they are wavy, right? So this is definitely a neurofibroma. To prove its neural origin, I need markers. I'll do an S100, right? That's all going to help me in the diagnosis, right? Perfect. When you look at this, so it's a low power image. Can I say that this entire thing looks like a nerve bundle? Yes, it's kind of an enclosed, right? So this also is like a tiny nerve bundle. This also is like a tiny nerve bundle. So this also is a tiny nerve bundle. It's so big. It's so huge, right? So when I have this huge nerve bundles, normal size of nerve bundles might be like this much, that's all. This might be the normal size of nerve bundles. I have so much huge nerve bundles, still they have maintained the shape, which means a damage must have happened somewhere in the center, which has grown it bigger in size, right? This is how a plexiform neurofibroma will look. That's the only difference. The appearance is the difference. Neurofibroma will be connected to a nerve. A plexiform neurofibroma originates from the nerve. When you look at this again, see here. Definitely you can see the outline. These are all nerve bundles which have been become bigger, right? That's how a plexiform neurofibroma looks, right? That's more diagnostic for neurofibromatosis, right? So you know about neurofibroma, we know about the pigmented appearance. I do have few things other than this. Just a second, where did it go? Apart from your neurofibromas and apart from your here. Next thing for me is I have few osseous lesions. Do you know any distinctive bony lesions which is diagnostic of neurofibromatosis? I'm sure this came in MCQ as well. You have sphenoidal problem, sphenoidal dysplasias, orbital pseudoarthrosis. That's very, very classical for a neurofibromatosis, right? Bone related, sphenoidal dysplasia, okay, and orbital pseudoarthrosis. Okay. Again, this is a more of a radiological diagnosis. You might not pick it up here. And one more MCQ which has come for you is your optic gliomas. Optic gliomas is also common in neurofibromatosis. Fine. These are all my classical findings seen in the patient. When I say it's autosomal dominant disorder, am I right in saying that this disease is will be definitely present in any one of the parent? Yes, so family history also becomes important for me here. A family history. So again, family history of neurofibroma alone is not enough. Family history with the same above features of neurofibromatosis type 1 is diagnosis, not type 2, because type 2 is a totally different gene, totally different presentation. We'll see that soon, right? So this is what I'm going to have. All these are criteria. Add one capillary spots, freckling in the axilla inguinal, annulus nodules. All three are related to your pigmented abnormalities. You have neurofibromas, plexiform in the normal, optic gliomas, maybe again nerve related, one bone lesion, and a family history, right? So we have 7 criteria. Of this, greater than 2 criteria presence is more than enough, which might include your 2 in this patient and a family history. That's more than enough. More than 2 of the above criteria is diagnostic. The only reason I'm requiring you to understand about this and diagnose them is definitely the patient, younger offspring or the sibling will have a 50% risk of having the problem. So we have to pick up the disease much earlier, and if we are able to pick up the disease, I'll be able to treat the disease as well. Fine. So we know about neurofibroma. We know about few lesions regarding neurofibromatosis type 1 as well. As I said that it's a problem happening in my RAS pathway, right? So we read lots about RAS pathway. Is there a possibility that I will have many other more disorders which can involve the RAS pathway? There's definitely a possibility, right? So this came in a question as well. Neurofibromatosis has been recently reclassified under a disease group called rasopathies. I'm sure you must have heard this. This came in MCQ. Which of the following are rasopathies, except we have few of them which is going to get abnormal in my RAS pathway. I'll just name the diseases. If at all something comes, it might help you. Obviously, the one which we'll be starting with is NF1. You must have heard about a syndrome called as Noonan syndrome. Noonan syndrome is an rasopathy. Again, I'm just going to give few of them. There are lots and lots of rasopathies. Few of them are not named. Few of them, I just know the mutations, right? Few of them are named. I have Legius syndrome, Leopard syndrome, Costello syndrome. Fine. One thing which came in JIPMER was Noonan syndrome. Noonan syndrome is a rasopathy. Hopefully, if something comes on the similar basis, you should be able to answer it. Something involving the RAS pathway, which can be a mutation in the RAS per se, or in a gap, or in any of the functional domains of RAS, which is going to cause a diffuse systemic involvement of disease, which I'm going to term as rasopathies. Fine. Okay, great. That's about your NF1, neurofibromatosis type 1. Go to NF2, neurofibromatosis type 2. For NF2, first again, we are going to go with the criteria. As I said, that NF2 has been updated a lot. Because if I say neurofibromatosis type 2, what is the first thing which comes to your mind? The first disease which comes to your mind is one disease in the CNS, which is Schwannomatosis, right? Schwannomatosis is the first thing which will come to your mind. It's an autosomal dominant disorder, obviously, right? It's very, very characterized by bilateral Schwannomatosis. Right? Bilateral vestibular Schwannomatosis is the hallmark of, or any cranial, it's a hallmark of neurofibromatosis type 2, right? So if I have a patient, I'm just giving you a possibility again. Is there a possibility a patient presented to you with one schwannoma, unilateral? Is there a possibility down the road, let's say 5 years later, the patient can develop a bilateral schwannoma? Is there a possibility? There is a possibility. Other side also, he or she can develop, right? So in that case, I cannot wait for the bilaterality to come into place. If the patient presents to me with bilateral schwannomas, very easy for me for diagnosis. If it is present unilateral, there's a possibility over the years the person can develop schwannoma on the other side as well. So I cannot always rely on bilateral schwannomas. So I need to change the criteria, right? The recent criteria laid down by NIH is called as the Manchester criteria. If the name comes, it might help you, right? It's called as Manchester criteria. So they have a little bit added few inclusions, just keeping in mind it might present as unilateral, later it can become bilateral, right? So here the presence of one or more of the following criteria is diagnostic, right? It's not two here, it's just one or more. The first thing, presence of bilateral vestibular schwannomas, definitely diagnostic. It's more than enough for me. When a patient presents to me with bilateral vestibular schwannoma, the first thing I'm going to think of neurofibromatosis and I'm going to evaluate for the genetic makeup, right? Second, I have a first degree relative, it should be first degree with neurofibromatosis type 2 and a unilateral schwannoma. Again, I'm saying that there is a familial history and the patient has a schwannoma, so definitely it's diagnostic, right? A positive family history of NF2 and unilateral schwannoma. So I'm not going to disregard any schwannomas. If it's unilateral, I'm going to go for your schwannomas, fine? I'm going to go for the family history. If schwannoma is not present, is there a possibility NF2 patient can have meningiomas, gliomas? Can they have neurofibromas? They can have it, right? So it's not just schwannoma, I have other abnormalities as well. Or again, I should have a positive family history. And if I go for other abnormalities, I cannot take only one lesion. I'm going to take two lesions, fine. Two of the following. Meningiomas is again possible. Can have an glioma possible. Schwannoma, which is not vestibular, in other areas possible. Neurofibroma possible. And one disorder in eye. Do you know anything which involves the eye? There's one disorder which is very, very characteristic. Posterior subcapsular cataracts, right? Okay. See, these are all the other lesions you have to remember, fine? So I'm going to give multiple permutation combinations of these 5 findings in addition to the classical vestibular schwannoma, and I'm going to alter the criteria, right? So first 2 things for me is bilateral schwannoma, definitely an important point. If it is unilateral, I'm going to go with the family history. Let's say that the patient's family history is not available. So in that condition, can I diagnose with unilateral vestibular schwannoma? Yes, I can. But again, I should have the other things. If I don't have a family history, third one, what I'm going to say is, I can have a unilateral vestibular schwannoma. I'm writing VSH for vestibular schwannoma. Plus, in addition to that, again, 2 of the above 5. I'm just writing above 5 to say that meningioma, glioma, schwannoma, and other sites, neurofibroma, and posterior subcapsular opacities. Fine. These. Okay. If I don't have gliomas, if I have more than one meningioma and vestibular schwannoma, that's also diagnostic. Right. Unilateral vestibular schwannoma plus multiple meningiomas, diagnostic. Multiple meningioma includes more than one also. Fine. So I have altered the criteria just to make sure that I am not going to wait for bilateral tumors. I'm going to evaluate the patient, take an MRI of the brain, which will show you multiple other tumors as well. Take a biopsy, prove it it's a problem, it's a meningioma. Most of the time, if you don't want a biopsy, you can prove it with radiology itself. Then I can classify the patient as neurofibromatosis type 2. Again, the only reason we are subclassifying this is there's a possibility in the sibling, there's a possibility in the offspring to have the disease. The good thing is we are living in an era that if I know that offspring, okay, TJ, ependymoma. When I say ependymoma, does it come under glioma? It is, right? So when I use a term glioma, it includes multiple subclassification in that, right? So that will automatically come inside it, right? Okay. So we are living in a place where if I diagnose neurofibromatosis in an adult, I can definitely prevent the disease in an offspring, right? In an offspring. Say in TSC that we have a variety of glioma called as an subependymal giant cell astrocytoma, fine? It's a different thing, that's all. Just a second. Okay. I can prevent that in offspring. That's why we have to go ahead and read, and we have to come to a diagnosis. You must have not seen these cases in an undergraduate time. It's not that I'm not seeing these cases, I'm kind of missing those cases. Definitely these cases are not rare. Neurofibromatosis is a common case. You must have seen cases, but we don't evaluate much. We don't give for genetic counseling. That is must and that should happen, right? So again, we are going to go to the pathogens of neurofibromatosis type 2. What is a gene mutated in neurofibromatosis type 2? If you know the protein's name, you must have heard about a protein called as Merlin, right? It's written there as well. Active Merlin is written. Actually, Merlin is a group of protein. When I take the NF2, the pathogenesis, I'm having 2 domains. Like it says that this is one protein domain, this is an inactive domain, fine? So when I say Merlin, Merlin is actually a part of it, that's all. Okay. So what happens is, Merlin is a combination of 3 proteins, right? Okay. Both of this constitute to form my NF2 protein product. The protein product is going to be a combination of both of these, fine? This Merlin, the MER is the short form. Any one of you guys can tell me what is MENR? It's seen in chromosome 22. Yes, absolutely correct. Anything? Anyone? I have three proteins which combine and we call it Merlin. M stands for your mucin, E stands for your resin, R stands for your radixin. If you want to know this, at least I need to know a little bit about resin. Resin is one of the gene which is responsible for spread of a tumor, right? It helps in spread very easily. That's why when I have a single lesion, right, this resin is important because it has metastatic potential. Let's assume I'm having a tumor here in one of the 8th cranial nerve, one vestibular schwannoma. Because of the resin problem, this can go to the other side. That's why bilaterality, multiple tumors are very common here. There we took only neurofibroma, right? Here everything, meningioma can be multiple, glioma can be multiple because of resin. Resin helps in your multiplication, resin helps in your metastatic potential, so that's the reason I'm going to much more concentrate on it, right? So this Merlin protein can also be called as Schwannomin. So if Merlin is not the option, look for Schwannomin. As Sia said, it's going to be there in chromosome 22, fine? So what happens here is, an inactive Merlin is going to be phosphorylated. Only when I have a growth factor receptor, it's going to become, it will suppress, this red part is for suppression, it will suppress this, right? When the growth factor, it's going to suppress this pathway and it's going to suppress cell proliferation. As I said that, there's also one tumor suppressor gene, fine? So in case of an NF2 mutation, I'm going to have the loss of this tumor suppressor gene. When that is completely lost, this pathway will be overtly activated, which results in overt cell proliferation. That's what I'm going to see in your neurofibromatosis type 2, the pathogenesis, right? So since we know the pathogenesis, and we have to just go a little bit and understand about schwannomas. You know about schwannomas, so I'm not going to go in much in detail. You're going to tell me everything about schwannomas, right from your finding till your MRI and your microscope, right? Schwannomas can be multiple. Schwannomas can be seen everywhere. Don't think that it's always seen only in your vestibular region, only in cranial nerve. That's more common, that's all. It can be seen even in your cauda equina. The first image which I showed you, this background image here is actually the cauda equina fibers. There are multiple schwannomas in the cauda equina fibers, right? So it can be seen in any nerve. It can be seen in a peripheral nerve also. It's not always central nerve. It can be seen in CNS and can be seen in peripheral nervous system, anywhere, right? They are well encapsulated lesion, well circumscribed lesion, right? Obviously, the first thing is going to be your cranial nerve 8 involvement. When I have a clinical history of schwannoma, what do you think? How do you think a patient with vestibular schwannoma will present? The presentation finding will most likely be classical tinnitus and then sensory neural hearing loss. That will be the most common presenting finding. In addition to that, one unique thing about schwannomas is there can be multiple cranial nerve palsies. Think of this. When you have a patient with multiple cranial nerve palsies, think there is a possibility of a vestibular schwannoma happening here. That's all, right? So when you go to the microscopy, like you guys said, we know the neurofibroma, same wavy fibers will be the same elongated findings. But apart from that, we have your Antony A, the classical Antony A, Antony B. Antony A is hypercellular, Antony B is hypocellular areas, fine. And in the area of hypercellularity, I have a structure called as a Verroque body. Okay, Verroque body is diagnostic, fine. So Verroque body, when I see, it's diagnostic. Verroque body is nothing but all the hypercellular areas. Let's say that there is lots of cells here, all the spindle rod wavy cells. This comes and arranges itself parallelly. And when these are nerve fibers, right? So nerve fibers will have lots of cytoplasm attached to it. The cell cytoplasm looks like this. And this palisaded appearance is called as a Verroque body, fine. And the pink color here is the cell cytoplasm, nothing else, fine. So this entire structure which happens in a hypercellular area is called as a Verroque body, fine. If I need an IHC, I'm going to go with the same IHC, it will be ascendant positive. So in your NF2, it's not only schwannoma, I can have malignant peripheral nerve sheath tumor as well. MPNSC is also possible. MPNSC stands for malignant peripheral nerve sheath tumor. Schwannoma is a nerve sheath, right? So you can have a malignant peripheral nerve sheath tumor, which means the same appearance with lots of pleomorphism, mitosis, and necrosis, right? That's what I'm going to call an MPNST. Just remember this name. If I'm not going to give schwannoma in the history, I'll give MPNST in the history, right? Okay. That's the simple thing about schwannoma. I'm not going to go in detail about it, right? We'll go to the third disease. This disease I wanted to discuss a little bit in detail because we have not read about schwannomatosis. There's a unique condition called schwannomatosis, which has a molecular diagnostic criteria, which has a clinical diagnostic criteria, where I have definitive diagnosis and possible diagnosis. I had put a question in the Telegram group, right? 4-hit pathogenesis mechanism. I was asking for a tumor. You guys answered NASH. NASH is also, it's not 4-hit, NASH is multi-hit pathogenesis model. 4-hit pathogenesis model is classically seen in schwannomatosis, right? Third disease, the syndromic thing we are going to see is schwannomatosis, right? Here I'm going to have schwannomas, 2 or more multiple schwannomas, multiple meningiomas. The problem here is it's not a thing which is associated with NF2 gene mutation. NF2 is in chromosome 22. It's not a germline mutation of NF2, it's an acquired mutation of NF2, but a germline mutation of one more gene called as SMARCB1. That's also seen in your 22 chromosome QR. It's very close to my NF2 gene, right? It's an autosomal dominant disorder where I'm going to have a germline mutation in SMARC. SMARC group of genes are very common these days in diagnosis. It's not the SMARC, we have a list of tumors called as INI deficient tumors in which the SMARC gene mutation is going to happen, right? This is also there in chromosome 22. In addition to this, I'll have acquired loss or an acquired mutation in my NF2 gene. So it's going to be 4 hits. SMARC is also a tumor suppressor. So I should have 2 hits in SMARC and 2 hits in NF2. Then only the patient is going to come to your diagnosis. That's why I call it a 4-hit pathogenesis model, right? So I'll have 2 hits here or 2 mutations here. I'll have 2 hits here, 2 mutations here. Both in addition, I'm going to have a 4-hit pathogenesis model. Okay. That's diagnosis of my seen in schwannomatosis. I said my diagnostic criteria is very, very important for you. As there are 2 types of diagnostic criteria. One is molecular based diagnostic criteria and one is clinical based diagnostic criteria. When I say clinical based diagnostic criteria, I can take in consideration your clinical thing as well. Okay, the iPad is not seen, so ignore it, fine. Good observation, group. Okay. So when I come to the diagnostic criteria, the first one is my molecular based diagnostic criteria. Molecular based definitive diagnostic criteria. When I have this, I can say that for sure it is your schwannomatosis. I should have 2 or more schwannomas or meningiomas which has to be pathologically proven. I cannot go with MRI diagnosis alone here. It has to be biopsy. It has to be proven it is schwannoma or a meningioma. Right? You cannot go with clinical. That's why we put molecular and pathology based criteria. Right? I should have 2 or more schwannomas, or I can have meningiomas as well. Again, 2 or more schwannomas or 2 or more meningiomas. It should be biopsy proven. That's more important. Not only that, in addition to that, I say it's molecular, right? I have to do a genetic study to say there's a loss of heterozygosity in chromosome 22 and NF2 mutations as well. In addition to this, I need genetic analysis to explain my 4-hit pathogenesis model. I should have loss of heterozygosity, means homozygous means both are normal. If you remember Knudsen's 2-hit hypothesis, we say that the first hit will happen at the birth, right? Which means I'm right in saying that any condition, let's take retinoblastoma only. When the first hit happens at birth, I'm going to evaluate the patient's genetic analysis. Am I right in saying that the patient is heterozygous for that retinoblastoma gene? One is normal, one is mutant. Yes? Right? So when I say loss of heterozygosity, this heterozygosity, the other one also gets mutated, which means the heterozygosity is lost, which means the acquired mutation is also there. Fine? So when I say genetic analysis, this should happen in, again, 2 tumors. It's not in germline, it should happen in the tumor tissue. I have to evaluate in 2 tumors. I should have LOH. LOH stands for loss of heterozygosity. I'll explain this a little bit more again. In chromosome 22. In addition to that, 2 different NF2 mutations. When I say this, I'm diagnostic of an schwannomatosis. I'll just go back before coming to the clinical criteria. I'll just explain loss of heterozygosity. When I say LOH, let's take RBG and your Knutson's hypothesis. What Knutson's hypothesis said was, at birth, what will happen is there will be one mutation. There will be one mutation at birth, which means at birth, if I take my retinoblastoma, let's take these are my 2 chromosomes of retinoblastoma, one is gone, which means here it's already heterozygous at birth. They're not homozygous. At birth still they're heterozygous. When I say this heterozygosity is lost, which means when I have a second acquired mutation, I'm right in saying that both of them becomes mutated, right? When both becomes mutated, I'm going to call it homozygous. Homozygous mutant, not homozygous normal. When this happens, I'll have homozygous mutant. Homo means same, that's all, right? Both of them are same and both of them are mutated. So this from heterozygosity becoming homozygosity is called as loss of heterozygosity, right? When I say loss of heterozygosity for chromosome 22, the SMARCB1 mutation is present at birth, one is acquired, so the loss of heterozygosity happens, and I should have the 2 NF2 mutations, which takes it 4-hit pathogenic model, right? That's my molecular based diagnostic criteria. When I come to clinical diagnostic criteria, clinical includes if I'm not able to get an molecular genetic testing done, what can I do? Again, I should have 2 or more schwannomas. Okay. The criteria is very specific that 2 or more schwannomas, in that it should be non-dermal. I cannot have a dermal schwannoma. It should be in the central nervous system, right? It's non-dermal schwannomas or in a deep organ. And it should be biopsy proven. At least one should be biopsy proven amongst that. In addition to that, okay, there should be no bilateral vestibular schwannomas. That's very important, because since I'm not using the molecular diagnostic criteria, which means I'm not using your SMARCB1 mutation, I have to rule out neurofibromatosis type 2, right? Bilateral vestibular schwannomas should be eliminated. This can be eliminated even by an MRI. Do an MRI, make sure that there's only one side and there's no bilateral. Because when bilateral vestibular schwannomas is there, I'll have a confusion between neurofibromatosis and my schwannomatosis. Why I am discussing about schwannomatosis, I am sure you must have not heard much about schwannomatosis. It's a very close differential diagnosis of neurofibromatosis. You have to think schwannomatosis also in your mind when you have a unilateral vestibular schwannoma and you're going to diagnose based on clinical finding alone. Just do a microscopic analysis. The reason is SMARCB1 is a very, very dangerous thing. I'll have multiple other tumors which might be very aggressive and the prognosis drops a lot. But NF2 prognosis is not so fatal compared to my schwannomatosis. That's the only reason we have to consider this much more. Fine. Okay. This should be more than enough. There are a few more criteria as well. I'm not going into the depths of it. Just a molecular based criteria and a clinical based criteria and your 4-hit pathogenic model. If you know that, that should be more than enough. Fine. Just have a little bit of time. I'll discuss about tuberous sclerosis. Since we did talk about SEGA, I'll look at SEGA and then your two other microscopic finding for tuberous sclerosis. I'm not going to the criteria here because it's an exhaustive criteria. I'm just going to look at 3 classical lesions in neurofibromatosis. Tell me what comes to your mind when you think of neurofibromatosis. Like what tumor comes to your mind? What tumor comes to your mind when you think of tuberous sclerosis? One is SEGA. Apart from SEGA, what else comes to your mind? Apart from SEGA, what else comes to your mind? Okay, so the first thing I'm going to help in your diagnosis of SEG. It's astrocytoma, tuberous sclerosis, not NF1. So you have subependymal giant cell astrocytoma. You have subependymal giant cell astrocytoma. When I say subependymal giant cell astrocytoma, that's a very, very classical finding seen in tuberous sclerosis. Don't mistake this giant cell to be our routine giant cell. Whenever we think about giant cell, what comes to our mind is the multinucleation, right? Here, it will not be multinucleation. It's an ependymal lesion which will be picked up on an MRI, and when you take a biopsy, you'll have a huge ugly cell. That's what I'm going to call the giant cell, right? So this is a low power image. One finding is classical here is you can see the pattern. It's having like an radiating pattern of thing, And even in this low power, you can see that definitely there are multiple abnormal size cells here. When you go to the higher power, you can see that definitely I have a normal size cell here, At the same time, let me use a different color. Whatever I'm circling in pink color are definitely bigger cells. These are the ones I'm going to call it giant cells. An ugly looking cell. It's not multinucleated. The giant cell here is just a pleomorphic cell, that's all. It's two pleomorphic cell. That's what I'm going to call it in SEGA. The thing why SEGA should be concentrated much more is it's not a very high grade tumor. Though in microscopy it looks very high grade, right? When you look at the microscopy of this lesion, it looks like it is at least 3 or 4 grade. It's pleomorphic. But SEGA even said that it's an WHO grade 1 tumor. Fine. It's a grade 1 tumor of WHO, but it looks ugly, that's all. I won't have mitosis, I won't have necrosis, I won't have endothelial proliferation, so I'm going to call it an WHO grade 1 tumor only. The very close differential diagnosis of SEGA is your gemistocytic astrocytoma. Okay. There's a very close differential diagnosis of SEGA on a microscopy. Again, if you are experienced in your neuropathology, it will not be difficult as well. This is a DD for SEGA. It should be differentiated because gemistocytic astrocytoma is grade 3 or 4. It's a high grade tumor. You have to differentiate. A gemistocytic astrocytoma looks like this. Look here. Here again, I'll have giant cells. Again, an abundant pink cytoplasm. Same thing. What's there? When you look at a gemistocyte, it will have a glassy appearance. It looks kind of your Russell bodies in your plasma cell. The appearance gives me the clue, and the fibers, the background fibers, the pattern, the radiating pattern will not be present here. And gemistocytic astrocytoma is not an ependymal lesion. It happens more in the cortical lesion. So my location and the microscopic appearance of the fibrous nature, the world appearance, the pattern, and the glassiness of cytoplasm helps me to differentiate this and that. Because the prognosis changes and my etiology is going to change. Whenever you see a patient SEGA, the first thing I'm going to suspect is tuberous sclerosis. You have to evaluate for tuberous sclerosis. Make sure tuberous sclerosis can be acquired. There are lots of times tuberous sclerosis can be acquired, which means I'm not going to always rely on my family history, right? We don't rely on the family history. Even if you look at your criteria of tuberous sclerosis, which we'll maybe discuss tomorrow, I will put it up in the Telegram group, there'll be nothing mentioning about the family history. It can be completely acquired. I won't have the criteria as well. On the other hand, neurofibromatosis 1 and 2, family history is important. It's unlikely to be acquired, right? This can be easily acquired, so family history, please disregard it. It's just based on major and minor criteria, microscopic criteria, and MRI based criteria, fine. Second is heart. What I'm going to see in heart is rhabdomyoma. So rhabdomyoma is a classical finding seen in tuberous sclerosis. Again, here when I see a cardiac rhabdomyoma, it's more commonly seen in children. You have to suspect tuberous sclerosis and evaluate for tuberous sclerosis 1 as well as tuberous sclerosis 2 gene. We'll look at the pathogenesis, everything tomorrow, fine. So when I say cardiac rhabdomyoma, one cell which helps me in diagnostic point is spider cells. What is the other tumor which comes in the heart? There's one more tumor which comes in the heart, which is myxoma, right? Myxoma has a cell which is called as an stellate cell. Stellate cell and spider cell more or less looks the same, right? Here I have something called a spider cell. This is how a spider cell looks. Look here, I'll explain why the spider cell has this appearance. Right? This leaf cell, this is a cell, it kind of looks like a spider, right? I'm having a muscle. Am I right in saying that any muscle will have stores of glycogen? Any muscle in my body will have glycogen stores? Yes, for sure. So cardiac muscle also will have lots of glycogen stores, right? Yes. So when I have lots of glycogen stores, that muscle becomes a tumor. This tumor, let's say that I'm having a muscle like this, I'm having a tumor here. Do you think this tumor will contract? Will it have the property of the muscle in functional property? It won't. This muscle, the ventricle, let's say it's ventricle, it's more common the ventricle, by the way. Ventricles will contract, this tumor will not contract, which means this tumor comes from a cardiac muscle, which will have the microscopic characters of cardiac muscle, which will store glycogen a lot, but is not using the glycogen. So this gives the empty appearance. This empty appearance predominantly is an artifact or due to glycogen. Fine. So because of the empty appearance, the normal cytoplasm color is pink. There's lots of empty vacuoles in there, which gives the emptiness, which gives the normal cytoplasm become like a fiber. that gives a spider cell appearance, right? There's a reason for spider cell, and it's diagnostic point. I don't want you to pick up on a microscopy. At least just remember that spider cell is one thing I'm going to look for in your cardiac rhabdomyoma. And as I said that, I'll look, you can see a stellate cell in a cardiac myxoma, fine. One more tumor, I'm going to be worried. If I see the tumor, I'm going to think of tuberous sclerosis in renal. You have a tumor, this I discussed in one of the questions. What organ is this? You can see the glomerulus here. You can see tiny glomerulus here. It's renal, right? It's kidney. Right. And in this kidney biopsy, what are these structures? Clear areas. It's fat. Definitely it's fat, right? You can see fat. In addition to that, I'm sure you can appreciate this. What are these? It's a very simple one. That's your vessels, right? I can see vessels, I can see fat. I'm seeing fat, I'm seeing vessel. And definitely here, there are few mesenchymal tissues. Though it's a low power, I'm not able to see it. That's your muscle fiber, right? So I'm having angio, that is vessel. Having myo, the muscle fiber. And having the fat, lipoma. Angiomyolipoma is also very characteristic of your tuberous sclerosis. You have to look for tuberous sclerosis whenever you see a patient of an, think of tuberous sclerosis whenever you see a patient of an angiomyolipoma. It's a benign lesion, that's not the problem. The patient will have lots of other attached problems that will be the problem in your angiomyolipoma, right? Just go a little bit into the criteria of tuberous sclerosis. As I said, that there is a major and minor criteria. When I say a major criteria, I'll have lots of major criteria. You should have either two major criteria or one major with two minor criteria. That will give me my definitive diagnosis of neurofibromatosis, tuberous sclerosis. Right? I'm confusing NF1 and tuberous sclerosis. Fine. Again, I have here hypomelanotic macules. It's not hyper. It's not like cafe. More than 3 hypomelanotic macules, and it should be greater than 5 millimeter diameter. That is the first of the major. Second, angiofibromas can be seen anywhere. I should have more than 3 angiofibromas throughout the body. It's not angiomyolipoma, angiofibromas. It's like a fibroma with lots of vascularity. And third, angular fibromas. You must have heard a different name for this. And angular is beneath the fingernail bed, right? What's the other name for this? You must have heard of skin tumors, right? More than 2 angular fibromas should be there. And these are neurocutaneous syndromes, right? Sjogren's patches. Okay. This is more of a clinical diagnosis. I don't want biopsy to prove it's a Sjogren patch. Fine. Retinal hematomas. Retina is also a CNS involved thing, right? It's neural. It should be multiple retinal hematoma, not just one. Only when there's multiple retinal hematoma, I'm going to include it as one of the criteria to diagnose my NF1. Fine. Cortical problems. When I say cortex, the brain cortex, I can have tubers, which are tumors. I can have white matter abnormalities, which can be picked up on MRI. I'm just going to group them as cortical dysplasias. There are lots of findings. All of them can be considered as a finding for tuberous sclerosis. Then what we saw, SIGA. That's one of the important things. That's one of the major criteria. So definitely you have to remember about SIGAs. Cardiac rhabdomyoma. Again, a major criteria. Okay. Fine. And when I come to angiomyolipoma, I should have more than 2. I'm reading AML for angiomyolipoma, right? So these 3 is what we saw, and all of them are major criteria. When I have 2 of them, I'm going to suspect tuberous sclerosis. 2 major features are more than enough to call it tuberous sclerosis clinically. Definitely, you have to do a genetic study. If it is positive, go for a familial counseling. Go for a counseling in the family, right? Of offspring or the siblings, because it's autosomal dominant. 50% chance both the offspring and the sibling has, right? When I come to the minor features of tuberous sclerosis, minor features, again, you have lots of skin lesions. I can have dental enamel pits and intraoral fibromas. The pits of dental enamel, it's again a very common finding seen in many associated diseases, right? Like a nail pits, you'll have dental enamel pits. I should have more than 4 dental pits, right? and you have more than 2 intraoral fibromas. It should be biopsy proven as fibromas. Why I am having more than 2 fibromas is one of the problem in oral cavities. You must have definitely bitten your mouth multiple times, the oral mucosa. Whenever you bite, I can have a tiny healing process, fibrous tissue. When you keep on biting irregular edges, you can have fibromas commonly. So I cannot take one, I should have more than one, right? So then I have multiple renal cysts. It's not just angiomyolipoma, I have renal cysts. That also I'm going to consider as a criteria for my tuberous sclerosis. And your retinal patches, retinal achromic patches. No color, achromic patches in retina, all these are considered minor criteria. How will I diagnose NF2 is 2 major features. I'm going to call it NF2 definitive diagnosis, or I shall have 1 major feature and I shall have 2 minor features, more than 2 minor features. Then I'll call it again diagnosis of tuberous sclerosis. Sorry if I'm mixing it with NF2, right? So this is how you diagnose your tuberous sclerosis. We saw these three requires more thing. You might get an MCQ based on the microscopy of either of these 3 and ask what is the probable thing I'm going to look for, right? It's going to be tuberous sclerosis. There are 2 genes, TS1 and TS2. What is the chromosome number for TS1? Tuberous sclerosis 1 gene is seen where? And which chromosome? Tuberous sclerosis 1 is seen in chromosome 9. This was asked once, 9q. And tuberous sclerosis 2 gene is seen in chromosome 16p. TS2 was not asked, TS1 was asked. Definitely TS1 is more common. When it's a sporadic disease, TS2 is more common than TS1. In an inherited thing, TS1 is definitely more common than TS2. Right? Okay. Fine. Thank you for your time today. We'll be discussing about the other things. I will look at your von Hippel-Lindau syndrome, Cowden-Turcott, neovasal carcinoma, and rhabdoid tumors. Rhabdoid tumors again is an increasing entity. We'll have to look at that. We'll look at them tomorrow. Fine. Thank you for your time. See you soon. Bye bye. Till tomorrow at 10 a.m. We'll see. Bye.